Hello, and welcome to Talking About Tumors with Ryan and Ryan. I'm Ryan Holstein.
And I'm Ryan Clin.
And today we're going to continue our lung cancer discussions and move into a specific subtype of small cell lung cancer.
Hope everybody is enjoying the beginning of fall. I know that it's my favorite season. Love the pumpkin spice lattes and pumpkin beer with the cinnamon sugar trim.
Small cell lung cancer, as many of you may have already seen or know, is one of the most aggressive variants of lung cancer. This has been studied for many years, and unfortunately we haven't seen a whole lot of improvements in our approach to care going as far back as the 1970s, 1980s. So a lot of the discussion we're going to be giving today will be kind of based upon evidence from that time. There have been some small improvements more recently, and hopefully those will pave the way to bigger changes as we move forward. But still one of the poorest prognoses of cancer that we see.
If you do any inpatient rotations, then you'll probably see small cell lung cancer, as given how aggressive it is one of the cancers that we tend to treat inpatient when patients first present. So even if you're not planning on specializing in thoracic cancer, if you do any inpatient rotations, you'll probably see patients with small cell lung cancer and may even be giving them chemo as an inpatient. So definitely a good disease site to know.
Yeah, whereas cancers like prostate cancer or colon cancer, you're going to get a story of feeling weak over the course of months. You may, with small cell lung cancer, have someone feeling quite ill over a short period of time. And many scans, especially for those lung cancer is bad enough to require hospital presentation, you're going to have multifocal disease. The staging and workup for small cell lung cancer is the same as non-small cell lung cancer. So if you remember, we're going to need a biopsy, we're going to need full body scans, we're going to need MRIs of the brain. This is a multi-step process that delays in the natural timing of an outpatient workup may not be adequate in order to treat these patients before they become too unwell to receive treatment. This will also be one of the cancers where you may see someone with a functional status of an ECOG closer to 3 who may end up being candidates for chemotherapy. As we'll get to, these are very chemosensitive pathologies and patients may have a rapid response. And you may have someone who's highly deconditioned who actually has an improvement in functional status shortly after the chemotherapy starts to take effect.
As with most lung cancer, but particularly with small cell lung cancer, these patients tend to be very, very heavy smokers. This is a very rare disease in people with no smoking history. Now, once you suspect small cell lung cancer and get your biopsy, one thing to look for on the biopsy report, some of the buzzwords that you'll see also in board questions, is positive for chromogranin and synaptophysin. These are the neuroendocrine markers. Small cell lung cancer is a neuroendocrine tumor, and as we've said in other disease sites, other high-grade neuroendocrine tumors can be treated similarly to small cell lung cancer.
Some other markers that'll be positive on pathology are TTF1. If you recall, that's positive in many of our lung cancers. Maybe positive for keratin as well.
And these tumors also tend to be centrally located on your radiology. I remember from medical school, one of the mnemonics for small cell lung cancer was the 4 S's. They're not all S's, but smoker, central, not with an S, but with a C, obviously, small blue cells, and I think the last one was surgery, but really no surgery, because surgery, as we'll see, is not really a useful tool.
Probably a good way to remember for the basics, although pretty loose usage of the S's there. And if you recall back to our earlier discussion when we went over the overview of lung cancer as a whole, we discussed all the paraneoplastic syndromes. And although these can be seen in non-small cell lung cancer, and there were certain ones, small cell lung cancer is most notorious for having paraneoplastic presentations, and this runs the gamut from SIADH, Lambert-Eaton syndrome, limbic encephalopathy, and cerebellar degeneration.
You can also see Cushing syndrome from ectopic ACTH production.
And it's not uncommon that these paraneoplastic syndromes or possibly local invasions, such as in the SVC, will require urgent approach to take care of complications of the disease before you can start treatment. However, ultimately, the way of keeping these things under control for longest will be effective chemotherapy. Staging for small cell lung cancer is by the same method that we stage non-small cell lung cancer using the TNM criteria. And this should be done. It does help prognosticate these patients. However, when we're talking about how we're going to direct treatment, small cell has been broken up into 2 classes for decades now that still remains the standard way of approaching how we're going to treat these tumors. And this is either what we call limited stage or extensive stage. Essentially, limited stage is when the tumor and any lymphadenopathy is confined to one hemithorax and within a region that a single radiation field can target.
I really like the staging system because it's pretty simple compared to some of the other ones. Either limited stage and then everything else is extensive stage, so much easier to remember. It's also important to involve the radiation oncologist in the staging because the definition of whether or not everything can be located in a radiation field depends on the location of the tumor, but also the pulmonary reserve of the patient. So all of these should be multidisciplinary discussions.
Very rarely you're going to have a T1 or a T2 tumor that can be surgically resected. This is more often than not going to be an incidental finding, usually not symptomatic presentation. If that is the case and surgery is done, evidence is lacking, but often we'll use adjuvant chemotherapy using one of the standard regimens, which we'll get to, which is usually either cisplatin or carboplatin combined with etoposide.
Yeah, these small tumors are pretty rare, so a lot of times surgery is done even to just confirm the diagnosis because it is so rare to have such a small cell lung cancer without node involvement. And you should make sure when you're doing the surgery for these patients that these patients are getting mediastinal node sampling to really confirm that there's no mediastinal node involvement. So small cell lung cancer is pretty chemo and radiation sensitive. The problem being that these are not long-lasting responses and that most patients do relapse. And at that time, there's not really many options. The first-line treatment is concurrent chemo radiation using cisplatin etoposide doublet for 4 cycles. There were older regimens that were used, such as Cytoxan, epirubicin, and vincristine. And in the limited stage setting, cisplatin and etoposide was found to be superior with a 5-year overall survival of 10% versus 3%. So again, not great results there, but a small improvement over the Cytoxan, epirubicin, vincristine. Overall survival was 14 months versus 10 months.
Have been actually a few studies comparing the CAV regimen as it was known to EP or cisplatin and etoposide. Varying results. The limited stage, there was a potential improvement in overall survival. An extensive stage, they seem maybe comparable. Ultimately, cisplatin or carboplatin with etoposide has become our preferred standard as this is more tolerable and is at least as equivalent, maybe better in some cases. When we say good overall response rates, we're looking at response rates of 90%, 90. So if you recall back to our GI tumor discussions, giving things like FOLFOX or FOLFIRI, we're looking at response rates of 30 to 40%, and that's what we often will see in a solid tumor. So 90% is incredibly good for a solid tumor getting a response, and would be similar to what we would see in something like lymphoma. However, as Ryan mentioned, these are not permanent responses. It's thought that small cell cells have many mutations. These have led to many opportunities to develop drug resistance at the time of recurrence. So because these many mutations, these are fast-growing cells are chemosensitive. Once they find a way around chemotherapy, they become very refractory to further therapy moving forward. The current approach when using cisplatin etoposide in the limited stage may vary from center to center, but the most standard approach is using cisplatin 80 milligrams per meter squared given on day 1. Etoposide given as 100 milligrams per meter squared on day 1, 2, and 3. And this is repeated on every 21-day cycle. Etoposide can be given as oral or IV. The best studied in small cell lung cancer is as an IV regimen. Radiation is given during one of these cycles. So we do not give concurrent radiation through the whole course of chemotherapy. There were some studies showing that giving the radiation sooner leads to better long-term outcomes and local control. So we try to give the radiation as soon as possible. In clinical practice, it's very uncommon to have the opportunity to get a patient with limited stage getting concurrent chemoradiation on the first cycle. This may happen if all the steps fall into place perfectly, but because we're trying not to delay chemotherapy any longer than necessary, more often than not, patients will receive their first cycle of chemotherapy and then have the radiation combined with cycle 2.
There were studies comparing twice a day for a total of 45 gray of radiation. As you can imagine, especially as an outpatient, coming in for radiation twice a day can be pretty problematic for some patients. Initially, the 2 times a day radiation did look superior. However, when they increased the dose of the daily radiation, so 60 gray of radiation when you're getting it daily compared to 45 gray twice a day, those seemed to be comparable, and there was no overall survival difference. So in practice, you have the option of either doing radiation 2 times a day for a total of 45 gray or daily radiation for a total of 60 gray.
Yeah, this is a tricky thing with some of the radiation trials. The total gray given over the course may vary from time to time. and currently our standard of 60 to 70 gray given over 6 weeks.
As we know, cisplatin does have a few notable toxicities, particularly renal toxicity, ototoxicity, neuropathy. It causes a lot of nausea, vomiting. And carboplatin seems to be better tolerated, although at the expense of increased myelotoxicity. There have been studies looking at substituting carboplatin for cisplatin, both in the extensive stage setting and the limited stage setting. A meta-analysis was done looking at about 650 patients, although of those, only 32% had localized disease. And this showed that overall survival was similar with carbo-etoposide as compared to cisplatin etoposide. However, given that in limited stage we're aiming for cure, and that in these studies only, again, 30% of patients had limited stage, most oncologists still continue to use cisplatin in this setting.
Yeah, I would usually aim for cisplatin in localized disease. I mean, if the patient's not a candidate because of baseline renal function or baseline neuropathy, certainly is a reasonable option to switch to carboplatin. In that case, you would use an area under the curve of about 5 to 6.
And this is in contrast to extensive stage disease, which we'll get to, where we really have switched over to carboplatin just because of increased side effects with the cisplatin and similar outcomes.
Now, prior to incorporating radiation, we were using primarily chemotherapy in these patients. One question, of course, is how much added benefit are we getting with radiation? There was 2 major meta-analyses published in 1992, and this showed that radiation given over 6 weeks during the course of the cisplatin and etoposide did increase overall survival by approximately 5% at 3 years, with a hazard ratio of 0.86. And this is primarily due to local control. So we are seeing more people cured with the addition of radiation. With the best care that we're giving these patients, we are unfortunately looking at a 5-year overall survival of no greater than 10%. So we do have some patients that are cured, but that is not the average expectation. And median overall survival is around 2 years with limited stage disease.
Yeah, so we still have a lot of work to do in this setting. So of the patients with limited stage small cell lung cancer, 1/3 of patients will have brain-only relapse, and 1/3 of patients will have brain plus systemic disease relapse. So cranial mets are a very important comorbidity for these patients. So because of that, there have been trials looking at the administration of prophylactic whole brain radiation for patients after treatment of limited stage disease. So these trials looked at patients with a good response to chemoradiation and randomized them to either prophylactic whole brain radiation or not. In a meta-analysis of these trials, it did show that there was decreased brain metastasis, 33% versus 59%, and the 3-year overall survival was improved 15% to 20%. And because of that, it has been considered standard of care to add prophylactic brain radiation to these patients as long as they have a response to the initial chemoradiation.
This works out to be a hazard ratio for overall survival of 0.82. It's definitely significant, and we would encourage any treatments that can give such improvement in overall outcomes in patients. It is important to keep in mind some of the toxicities that come with this and some of the nuances with these trials given the time that they're run. First of all, with the toxicities, this radiation is whole brain radiation. So we're, in theory, bathing the brain with radiation with the hope of killing any micrometastatic disease. This, of course, would have expected short-term and long-term toxicities. Short-term, confusion, headaches, fatigue. Often this gets better. What is more of a concern are the long-term toxicities. And in general, this is not very well studied in patients because many of the diseases that we're giving whole brain radiation don't have good long-term outcomes. And those rare patients that do get long-term cure, it is not an uncommon finding for the clinician to see patients with long-term cognitive effects, dementia, and even possibility of radiation necrosis at late stage. I have at least one memorable anecdote of a patient with glioblastoma, so not small cell lung cancer, but received radiation, and one of those rare patients that had cure. And 20 years later, however, was still a young person and had essentially advanced dementia. Obviously, this still would have been the best treatment we would offer the patient. As we get more experience, we're always trying to find better ways to still provide the same optimal outcomes and minimizing some of these long-term irreversible toxicities. In the case of small cell lung cancer, All of the studies that were run were predating the MRI era for staging. The major meta-analyses that were run in the early 2000s did not include any studies that used MRI at baseline. So of course one of the questions is going to be, were these old studies that are showing improvement just radiating pre-existing CNS lesions that would have been seen if we had done an MRI? And in fact, in the extensive stage setting, there has been a more recent trial where we have done an MRI at baseline and randomized those patients with no evidence of lesions with MRI to close observation versus whole brain radiation. And in that case, survival was no longer improved. There's this equivalent trial ongoing in the limited stage setting called the Maverick trial. And I'm going to be very interested to see what the findings of that are. And hopefully we can limit the need for radiation in some patients who have given the sensitivity of MRI of detecting these.
Yeah, that's a really good point. I think the utility of prophylactic cranial irradiation, especially in the extensive stage setting, has really been questioned. And I'm sure similar studies may be done in the limited stage setting as well. Although for now, I think limited stage, there's still a push for brain radiation for those patients.
Yeah, it'd certainly be considered standard of care until trials show otherwise.
So we'll wait for those trials. So getting on to extensive stage small cell lung cancer, and again, the vast majority of patients, even with limited stage, will eventually progress to extensive stage. So most patients will develop extensive stage. The chemotherapy regimen is the same, a platinum doublet with either cisplatin or carboplatin and etoposide. As we've said previously, the use of carboplatin has really replaced the use of cisplatin, just given its less toxicity and that multiple randomized trials have shown equivalence in the extensive stage setting with no overall survival difference.
In extensive stage, we're not aiming for cure, so that marginal benefit of cisplatin becomes a lot less significant.
Yeah, definitely. Although you do have to keep an eye out for hematologic toxicity of carboplatin because it's much more myelosuppressive. Cisplatin etoposide was compared to cyclophosphamide, adriamycin, and vincristine, and in the extensive stage setting, there was no overall survival difference, and it is better tolerated than the 3-drug regimen, although the overall survival of both arms was still pretty poor at 8.6 months.
If the patient is presenting with evidence of CNS metastases or signs of SVC syndrome, these would likely take priority and you may need to do radiation to the brain, or if severe SVC syndrome, radiation to the lesion in that location prior to being able to start your chemotherapy. Prognosis for patients with extensive stage disease is incredibly poor. And although the response rates still remain greater than 90%, median overall survival is only around 12 months, even with our best treatments available at this time. And 5-year survival is around the range of 1% to 2%.
So one of the first breakthroughs that we've seen in years in small cell lung cancer has been the addition of immunotherapy in the first-line setting. This was studied in the Empower 133 study, looking at about 400 patients with extensive stage small cell lung cancer, adding the PD-L1 inhibitor atezolizumab to 4 cycles of carboplatin etoposide, and also with atezolizumab maintenance every 3 weeks until disease progression or toxicity. This study did show an overall survival benefit, although pretty modest, 12.3 months versus 10.3 months, and this was regardless of the PD-L1 status of the patient. The hazard ratio was 0.7. A similar study was also done using durvalumab, another PD-L1 inhibitor, the Caspian study, which added durvalumab. It showed a very similar overall survival benefit, 13 months versus 10.3 months. So right now, both durvalumab and atezolizumab are approved for use in the first-line setting for small cell lung cancer, along with maintenance after completion of chemotherapy until disease progression or unacceptable toxicity.
Checkpoint inhibitors were of high interest for small cell lung cancer patients. These, once again, are tumors with lots of mutations. If we recall from our other disease sites, high mutational burden or microsite satellite instability often hint sensitivity to immune checkpoint inhibitors. Fortunately, added benefit of 2 months of overall survival is small. There's maybe a hint of some long-term responders because of these. However, that does not seem to have the same impact as we've seen in melanoma or non-small cell lung cancer. There's no role for PD-L1 testing at this time. These trials were all done agnostic of any pre-specified biomarkers. And to date, there's no great biomarkers to identify who's going to be more sensitive than the others. Our standard of care with the chemotherapy is to use 4 to 6 cycles, although in general and in these trials, the majority of patients get 4 cycles. It seems to be as effective and removes some toxicity. It's also worth mentioning there was a third trial using pembrolizumab with almost the identical design as these trials, and this ended up being a negative trial. The median overall survival of 10.8 versus 9.7 months, hazard ratio of 0.8. This did not meet significance. This might have been a powering issue because this trial did use combined co-primary endpoints of PFS and OS. Due to the fact that this was negative, atezolizumab or durvalumab added to your chemotherapy would be your best option if they're available to you. If they're not available to you, probably not losing a whole lot in terms of big picture for these patients. It's unclear if these patients need an indefinite maintenance as was used in the trial, or it would be effective just to have 1 to 2 years of therapy. An approach may vary based upon where you are. But following the clinical trial, you would be giving these immune checkpoint inhibitors indefinitely after the response.
And as we've mentioned previously, patients that have had a response to the initial chemotherapy and immunotherapy, you can consider prophylactic brain radiation, although the overall survival benefit in the era of MRI surveillance has made this a little bit more questionable.
So, although small cell lung cancer typically will present with multifocal extensive disease when it is symptomatic, you may run into some uncommon situations where maybe a patient will have only one CNS metastases or maybe 1 or 2 painful bony lesions. And in these oligometastatic sites, although we don't have great evidence to support it beyond observational retrospective studies, we may try to proceed aggressively with these localized disease. And this may be treating with definitive radiation to the brain and treating with the limited stage approach to the thoracic disease. Another option may be if you have nearly complete response to chemotherapy but have residual disease in the chest, consolidative radiation to the chest may be considered after the completion of the chemotherapy. Once again, not common, but when we do have patients with poor prognosis and limited data to support our approach, we sometimes will try to do all we can to get this cancer under control. And often the thoracic disease is the most bulky and may need some extra treatment after the chemotherapy has completed.
Now looking at second line options, and again, none of these options are that great, to be completely honest, but the prognosis really depends on the time from your initial chemo to relapse. There have been studies showing that if your relapse is 3 months from your initial chemo radiation, then you have a better prognosis, and these would be considered platinum sensitive patients. Whereas if it's less than 3 months, then you're considered platinum resistant. Of course, performance status is also a predictor of prognosis in the relapse setting as well.
This is very analogous to ovarian cancer, where we will often subclassify these patients as platinum sensitive, platinum resistant, platinum refractory. The best evidence is looking at relapses greater than 6 months out from the final day of your chemotherapy cycle. For these patients, we would retreat again, often with the same regimen, carboplatin and etoposide, as response rates have approached greater than 40%. The durability of these responses are usually not as great. Anecdotally and in observations, on average about half as long as they would be in the initial setting, but some patients may continue to get long-term response from this, and this certainly would be the standard approach for these patients.
There was a randomized controlled trial of about 150 patients who relapsed after 3 months of receiving the carbo-etoposide. And these patients were randomized to repeating the carboplatin etoposide versus topotecan, which, as we'll get to, is another second-line treatment. The progression-free survival was increased 4.7 months versus 2.7 months. However, the benefit was really mostly seen in patients that had relapsed after 6 months of treatment rather than just 3 months. So that's why we usually reserve this regimen to people who progress after 6 months.
If they do progress in that 3 to 6 month window, decisions may be case by case, but often we'll hope that rechallenging with carboplatin and etoposide will work because our other agents such as topotecan do give pretty limited added benefit.
It's also important to note that these trials were done before the addition of immunotherapy, so it's still kind of unclear if someone was to relapse after 6 months, but while they're still on the immunotherapy maintenance, do we stop the maintenance or do we continue it? That's still kind of up in the air. There's no data to support one way or the other.
So looking at topotecan, this has been one of our best options for many years in the second line setting. This is a topoisomerase 1 inhibitor. So if you remember back to your basic sciences discussions, this plays a role in inhibiting the unwinding and rewinding of DNA during replication. This drug was studied in the second-line setting to recurrent or refractory small cell lung cancer. This was compared to best supportive care alone and power for overall survival. Topotecan is given as an oral agent dosed at 2.5 milligrams per meter squared per day on days 1 to 5 on an every 3-week cycle. So Monday through Friday, 2 weeks off, and then repeat. This did improve overall survival in this trial with an average of 6 versus 3.5 months. So 2.5 month improvement in overall survival. This was at the cost of some toxicity. If you remember, topotecan sounds a lot like irinotecan. So our toxicities are going to be very similar with primarily diarrhea, which had grade 3 up to 6%, fatigue, vomiting, lots of myelosuppression with about 60% grade 3 to 4 anemia, as well as neutropenia, although neutropenic fevers were relatively uncommon at 3%.
Another option at relapse is lurbinectedin, which is an alkylating agent and is dosed at 3.2 milligrams per meter squared, IV given every 3 weeks. So this was studied in a single-arm trial of about 100 patients without any brain metastasis that we knew of, who had progressed after carboplatin etoposide. Very few of these patients had received immunotherapy in the first line or were on immunotherapy maintenance just given when the trial was run. The overall response rate was 33%, and patients did do better if they had relapsed greater than 3 months after their last treatment. So the overall survival was 11.9 months for patients that relapsed after 3 months. And for patients that had relapsed within 3 months of their last treatment, the overall survival was only 5 months. The major toxicities of lurbinectedin are mostly hematologic. So given that this has never been compared to topotecan, it's unclear as far as sequencing which one you want to do first. So you can really base it on the side effect profile or patient preference.
Proponents of lurbinectedin comment on the fact that it has less myelosuppression, which may require less need for transfusions or GCSF support. Arguments against are that it doesn't have randomized control trial level data. It'd be very nice to see a comparative trial from this and topotecan to help guide us, in these to give best care to these patients. So this trial was actually one arm of a basket trial. I think it's worth mentioning basket and umbrella trials because these are showing up a lot more often in the molecular era. Basket trials are trials where we take a single drug and we aren't sure if it's going to work in one or more different disease sites. And what we'll do is we will open a trial where we have multiple single arms looking at each disease site that we think it may work in. In the case of lurbinectedin, there was, I think, 5 or 6 disease sites that were looked at. In addition to small cell lung cancer, we had disease like head and neck squamous cell carcinoma, endometrial cancer, as well as some other subsites. And any patient with a potentially sensitive subsite would be enrolled and studied individually in its own arm. So all the patients with small cell were looked at specifically, all the patients with head and neck cancer were looked at specifically, and these all published out independently. To date, to my knowledge, I think only 2 of the arms from lurbinectedin have been published. On the other side of things are what we call umbrella trials. And in this case, often we'll take a single disease site and do a next generation sequencing test looking for multiple mutations. And based upon the presence or absence of certain mutations, patients will be enrolled in a different arm and getting a different drug. So this is also often single-arm studies, although umbrella trials do allow for the potential to randomize, but in each arm, different drugs are being tested. So in basket trials, different diseases all getting the same drug. In umbrella, usually a single disease, but each arm getting a different drug. And just to make things more complicated, there are these larger trials called super umbrella trials where we're looking at multiple diseases. The most well-known of these would be called the NCI match trial. All patients went under a large NGS panel. And if they had a certain mutation present, they would be enrolled in different arms. And in the case of the NCI match, this was different disease sites. That's why it's a super umbrella and not a single umbrella, which would be just looking at one type of cancer. There are some good reviews of umbrella and basket designs, and we will include a link in our show notes. Other than topotecan and lurbinectedin, high-quality evidence is even more limited. Paclitaxel in some small studies has shown an objective response rate of 30%. And in that very rare case where you have a patient who's been through 2 or 3 lines of small cell and are still candidates for further chemotherapy, paclitaxel could be something considered. And I think it's also important to mention for those patients who relapse less than 3 months, we're really looking at a low likelihood of response. These are the most aggressive of small cell lung cancers. An equally acceptable option would be to proceed with best supportive care versus a 10% response rate of something like topotecan or lurbinectedin when they relapse less than 3 months.
Yeah, this is really an unmet need in oncology, looking for better treatments for these patients. Okay, so we'll wrap things up with some bottom lines. So small cell lung cancer is a very aggressive disease with high chemo radiation sensitivity, but pretty much all patients relapse and eventually develop metastatic disease. And at that time, there are pretty limited treatment options. So the outcomes are still poor.
Although TNM staging should be used for prognostication, more clinically practical are the limited stage or extensive stage classifications to drive how we treat these patients.
Small cell lung cancer is associated with many different paraneoplastic syndromes, so you want to keep an eye out for these, specifically some of the neurological ones like cerebellar degeneration, limbic encephalopathy, as well as things like SIADH or Cushing's syndrome.
CNS mets are very common, and MRI of the brain should be part of your initial staging workup. If brain metastases are identified, treatment for these should precede systemic chemotherapy.
In the very rare case of having a T1 or T2 and 0 small cell lung cancer, you can proceed with surgery with the addition of adjuvant chemotherapy. Although given how rare this is the data is mostly retrospective and extrapolated from limited stage disease.
In a patient with limited stage disease where the extent of disease burden is confined to one hemithorax within one radiation field, our standard of care would be 4 to 6 cycles of cisplatin and etoposide with radiation given for 6 weeks, ideally as soon as possible, although in clinical practice due to delays in starting radiation often will overlap with the second cycle of chemotherapy.
For extensive stage disease, we use a combination of chemotherapy and immunotherapy with either cisplatin or carboplatin plus etoposide plus either durvalumab or atezolizumab. The chemotherapy is given for 4 to 6 cycles and the immunotherapy is given with the chemotherapy and then as maintenance every 3 weeks until disease progression or unacceptable toxicity.
With this approach, initial response rates are around 90%. Unfortunately, relapses are expected, and the timing of the relapse will determine how you approach next. When these relapses are beyond 6 months, there's good evidence to support rechallenging with a platinum etoposide combination. It's within the 3 to 6 month window. We often will try to rechallenge with platinum and etoposide, although the expected response rates are much lower. For the more aggressive presentation, or as we get closer to 3 months or even less than 3 months, systemic therapy options will be something such as topotecan, lurbinectedin, or if the patient is having a poor functional status, would be best supportive care alone.
The use of prophylactic brain radiation has come into question given that now we stage everybody with MRI brain at baseline. However, for patients with limited stage disease that do have a response to chemoradiation, it is recommended to give prophylactic brain radiation after completion of chemoradiation.
If you have access to any of the clinical trials looking at omitting limited stage radiation to the brain, I would encourage to enroll patients on that. In the case of patients with extensive stage disease, the use of whole brain prophylactic cranial radiation has fallen from favor due to a negative clinical trial in the MRI era.
For patients with extensive stage disease, you can consider consolidative thoracic radiation if they have residual disease after chemoradiation in the thorax.
Thank you so much to all of you who've been listening and finding this helpful. Next discussion, we'll be trying to wrap up our lung cancers with some overview of mesothelioma as well as large cell lung cancer.
Yeah, thanks for listening, and thank you for everybody who has given us feedback, and hopefully everyone enjoys the fall.
Bye for now.
Take care. For more information, follow us on Twitter at Talking Tumors, or feel free to email us at talkingabouttumors@gmail.com.
Please rate and review the podcast. We really appreciate it.
And special shout out to our friend John Kim for all of his musical talents.
And he is the composer of the music that you're hearing right now. Talking About Tumors is not medical advice.
For medical advice, please contact your own healthcare provider.
Opinions stated on this podcast are by the Ryan who said it and no one else. We have no financial disclosures, and this is done purely on our own time to the sake of our enjoyment of the field of medical oncology. Thank you for listening, and see you next time.